Hello and good evening to one and all. I, Dr. Asavri Sawant, on behalf of Voice of Healthcare, welcome you all to the Healthcare Infrastructure Summit 2022, ensuring healthier care infrastructure for safer public life, organized by Voice of Healthcare and supported by Association of Healthcare Providers India, also supported by Quality and Accreditation Institute of India and powered by Apco worldwide. So, as we all are aware, 80% of infectious diseases are transferred by touch. In healthcare institutions, objects frequently touched by healthcare workers, patients, and visitors can serve as cesspool of contamination and formalities. Recognize that there is a particular need for long-term and sustainable solutions for safer public health infrastructure, which is beyond periodic disinfection of surfaces to tackle issues like hospital-acquired infections. Hence, our today's event is aimed at driving forward a knowledge session for advocacy, a road to safe public infrastructure in the post-pandemic area, and pay a special focus on healthcare infrastructures. For discussing the same in more detail, we have some very eminent guests here with us today. Please allow me to welcome Professor Dr. R. Chandrashekhar, who is the former Chief Architect of Ministry of Health and Family Welfare at Government of India and who is also the Chairman of IGBC Green Healthcare Rating. Welcome, sir. I also welcome Padma Shri Awardee, renowned Dr. M. Wali. He is he has been the former physician to three Indian presidents. He is currently the senior consultant of medicine at Sir Ganga Ram Hospital, New Delhi. Welcome, sir.
Thank you.
I welcome Mr. Neeraj Lal, who is the
Good
Chief
morning.
Operating Officer of Gujarat region of Apollo Hospitals International Limited. Welcome, sir.
Very good morning.
I also welcome Dr. Yash Paul Bhatia, who is the Managing Director of Astron Hospital and Healthcare Consultants Private Limited. Welcome, sir.
Good morning, everyone.
We also have Dr. Vk Rana, who is the founder and Chief Executive Officer of Quality and Accreditation Institute of India. He would be joining us very soon. Dr. Bhatia would be leading this session for us today. So now I hand it over to you, sir.
Thank you, Dr. Savri, and thanks, VOH, and for this healthcare infrastructure summit on this very, very important topic of the hospital-associated infections. We all know that this is one of the most dreaded problems that the hospitals face and the industry. When we keep on focusing on it, all the focus has been to look into the practices. We have been talking about looking into the internal air quality. We are talking about overall hand hygiene practices. We are talking about so many things, the antimicrobial resistance and other things. But over a period of time, a lot of focus has now started shifting to the genesis of these problems. And one of the areas which had not been into focus was look at the infrastructure. We have always had design follows function. But what we also have to understand that there's another triangle to it, that our outcomes, the healthcare outcomes, are dependent upon the hospital design. In fact, when we have been talking about evidence-based medicine, now the focus is also going very strongly in favor of evidence-based hospital design. That's a subject which has ultimately been understood. There are a lot of theories which have been put together and a lot of research which has been done over the past, that how the design has impacted the outcomes, the infection control practices, the adherence to quality parameters, and all that factor that we keep on talking. Until unless the hospital infrastructure addressed to it, we cannot focus on that. I had studied a particular presentation during the MRSA, and I used to be very fond of presenting that particular slide, where we come to think of it, there are more than 100 surfaces in a patient room which are touched, which are frequently touched, and which are the ones which become the biohazards in communicating of this particular dreaded problem of the hospital-associated healthcare infections. And because of that, now what we are really talking about it today, the bioburden in the commonly and highly touched surfaces, least looked into, and the most problemsome area of what we are talking about. Thanks to social media, there have been a number of such videos and such uh, circulations which have been there in the past, which have been highlighting this problem. But at the same time, those remain the casual component of what we are talking about. Today, we are looking into a very serious way how we address these problems, how we look into this problem, and how we take this forward. In fact, as has already been brought in the video, the key focus areas of today's discussion is reducing HAIs through advanced infrastructure design, importance of reducing bioburden in commonly highly touched surfaces, use of materials such as antimicrobial copper to reduce bioburden and in turn reduce HAIs, other advanced ways to support clear and safer healthcare infrastructure. The whole idea is to have a flow through on what it means, what happens, and what we can do to address this problem. And a very, very eminent group of people. Welcome, Dr. Vk Rana, to the show, and with Professor Chandrashekhar being there, with Dr. Wali, Dr. Rana, and Neeraj. I think we have a very, very expert and knowledgeable group of people who not only have the knowledge, who have the experience on ground on how to address to these things. So I welcome all of you, and I do hope that the end of this journey, the scientific journey today, we will be able to elaborate on what exactly these bioburdens are, how they get transmitted, and how they result into the impacted outputs of the healthcare delivery system. And at the end of the day, how does the overall impact of evidence-based hospital design will put this whole structure into place to ensure that we are able to take it forward. And now, to begin the session, I have our most eminent speaker, Professor Dr. Chandrashekhar. I have personally been interacting with him probably for more than, I think, more than 2 to 3 decades. I think we have been interacting with each other, and he's produced some of the most important landmark things in the country. He will be remembered for his contribution to the healthcare infrastructure of the country in a very big way by his, support to the Prime Minister's Swasthya Yojana and writing books and writing now the Green Building Council and so many other things. If we start talking about it, probably the whole session will be lost in enumerating his what he has contributed to the Indian healthcare system, not only Indian, actually global healthcare system. So today we will request him to give his keynote address on reducing hospital-associated infections by minimizing bioburden in highly touched surfaces through safer infrastructure. So over to Professor Chandrashekhar for his talk.
Good morning, everyone, and thank you very much, Dr. Bhatia, for those kind words. And in fact, I'm also delighted to see expert panel, and most of them I have been involved in some way or the other. I've been working, and today, just to talk about the reducing hospital-associated infection through improved infrastructure. So here, I'll just try to make a presentation. So I need a little slide sharing. Can you help me out? I'm just sharing the slide. Just let me know whether you are able to see it.
We can see, sir. Yes, sir.
You are able to see?
Yes.
Okay. So today we will be talking on reducing hospital-associated infection through improved infrastructure. I am going to touch upon some of the points. You see, there are variety of things. There are clinical parameter, there is an infrastructure parameter. You see, one question a patient may ask, am I safe in this hospital? That has a different meaning. His safety is also related with the structural and non-structural member should be safe enough so that he is protected. Clinically, he is protected from infection. So such kind of a parameter, what I thought that I'll touch upon some of the important issue which is generally ignored. Otherwise, most of the people are aware. So here, I'll start with the first thing I would like to say, as you are already, Dr. Bhatia has mentioned, that 80% of the infection is through touch surfaces. So hospital-associated infection, most infection that become clinically evident after 48 hours of hospitalization are considered as hospital-acquired. The direct cost of healthcare-associated infection in UK alone is 1 billion GBP each year. Remember, it is each year. And antimicrobial copper is the most effective touch surface material, killing greater than 99% of the bacteria within 2 hours of exposure. No other material such as silver containing coating, etc. comes closer to this. And antimicrobial copper, why copper? So copper and copper alloys have intrinsic antimicrobial properties with well-documented efficacy against a wide range of pathogens. The Copper Development Association has conducted a series of laboratory tests under the Environmental Protection Agency and good laboratory practices protocol that have provided evidence that the copper surface kills microbes in a matter of hours. Then there are two ways of controlling hospital-acquired infection. One is environmental control and another is administrative control. So we are here going to talk about the environmental control against the hospital-associated infection because we are more concerned with now infrastructure-related issue. Administrative is the SOPs, etc. what we do. So physical property of the antimicrobial copper. Antimicrobial copper isn't just pure copper. It's shortened of a host of copper alloys that can be formed into durable, wear-resistant, can stand up to harsh environment, and can retain details and finish over time. Affordable touch surfaces available in a variety of color and finishes option. So interior designer can always find a suitable decor media that's possible. It is not necessarily it has to be a pure copper. So product form with a combination of steel and antimicrobial copper. Some people always say that whole copper may be very expensive. So an antimicrobial product could be manufactured in combination of material. The touch surface could be in an antimicrobial copper and the remaining in the steel. So this is done in order to reduce the cost. And taking into account the budgets, it is expected of the industry to consider all antimicrobial copper products, and that is too in a very easy way. So now this is where we could see copper in hospital. You could see the handle where we touch. That is the portion which is going to be copper. Or like, in our regular toilet or even a grab bar. These are the area which there is a possibility. Even in the clinical parameter, the scissor, the knife, where you hold, and those are the area. And in an intensive care unit, you fitted with copper component. This is over the patient table, over the IV pole or monitor pen or bed lever or visitor chair arm. So this is how. And even the things which are used in a surgical this thing can be of a copper. And you could see the door handle, grab bar, even the chair, the armrest of the chair. These are the touch surfaces. And these are the patient room where the material can be used. Then these are actually, copper is a very famous and old traditional thing which we have been using. Over a period of time, we have left that. And that is how we are getting into all trouble. Here you can see a medical staff area where there is a possibility of infection. Even the stethoscope, this is the one a doctor is going to use it for various patients. And this is where the copper will be of a great help. The toilet seat, and there are do's and don'ts in the antimicrobial copper. So do is that use antimicrobial copper product as much as possible. Somebody asked the question, sir, where should I use? I can say, depending upon your parameter, you can use it all over, but start with the clinical area, particularly OT, ICU, HDU, and these are the critical, and then subsequently to every place, and also the place where maximum crowd is going to be there. And please ensure that no antimicrobial copper product is coated, waxed, or lacquered. The moment you do this coating, it will lose its property. So you have to be very careful. And we are not going to use a copper sticker to show that we are using copper. There is a regular format in which we have to understand that what is the percentage of copper and what is the other alloy which you have to mix it. And how you get different finishes? The antimicrobial product can be produced in different colors and finishes. However, in order to do so, the manufacturer would need to use different alloy that have been registered as an antimicrobial. You cannot just mix up any metal. And the chemical composition of each of these alloys varies significantly. And hence, the costing for the wanted finish might differ substantially. Nevertheless, the products can be given various color and finishes. Someone wants that it should be antimicrobial copper, but at the same time, it should have a look of a stainless steel. So he can add nickel. But nickel is not a very cheaper material, so your product cost may also go high. So these are how the component. Now you can see how this mouse, which has been computer mouse, is very commonly used by everybody, and sometimes somebody sneezes, he uses, and after that he goes away, somebody else comes. So this becomes another very big source of this thing where you can make it of copper. And in the public infrastructure, you have seen number of people traveling in this metro. They are holding bar, and at the same time the escalator handrail. This is already being done in Japan. And how to tell whether the antimicrobial product is genuine? So new product bear the CU plus mark, which signifies the products are capable of continuously killing pathogenic microbes even in between cleans. So they are listed among the offering from other companies in the product directory. You can always log on to www.antimicrobialcopper.org. You will get a lot of information on this and the way it has to be used also. And this is how the Cu plus symbol looks like, so that it shows that it is a genuine copper. Now, besides copper, you have to understand what kind of a material specification which you should use. It is a picture of a dialysis unit. You have to remember jointless, that is seamless floor, seamless wall, and seamless ceiling. Joint means infection. So wherever there is a joint, then you can always keep a track on that. The joint can be either filled up with epoxy or antimicrobial coat, or else it has to be taken note that it is a seamless kind of a thing. And hand wash station at different location, because COVID-19 has taught us various format to understand. A common man also can do what all. And then what kind of a wall finishes. You see, you can have the acrylic mineral surface. It is easy to maintain and it is also smooth. There is never any growth of any fungal or this thing. We use this wall even into the operation theater. And one point I would like to also emphasize, during Corona, we learned airborne infection. So indoor air quality plays a major role. So indoor air quality generally consists of particulate, gases and volatile organic compound, and UVGI is the solution. Why? Because up till now we were using filtration, or we are using the pressurization or a normal ventilation. Filtration, by doing that, you are trapping the pathogen, and there is a colony of pathogen in your filter bank. Now, after COVID, we have realized that you have to kill them. That means purification. So ultraviolet germicidal irradiation on coil or inside the duct or even upper UVGI finishes. And this is earlier we were only using it for airborne infection area of TB related issues. Now it has become a common affair because now COVID has taught a lot of lessons. And somebody always say, is it only for the centrally air conditioned? No, you can always use it. This is, we call it trap and kill technology, which can be made into central air cleaner, is suitable for all type of HVAC system, whether it is air handling unit, fan coil unit, ductable, TFA, HRA, cassette or split AC without any modification. We can even customize the system to fulfill your specification, because sometimes people say we are running a small nursing home and clinic. We don't have a main central AC. How can we protect ourselves? As you are aware that if you use a air purifier and for getting efficiency, you have to close all the doors and windows. And when you close everything, the CO2 level rises. So you have to have challenges at different level. So it has to be thought in a composite way. And this test result, we have seen that it has a SARS-CoV or virus kill rate up to 99%, H1N1, bacteria kill rate to 100%, and PM 2.5 reduction is PM 1 point is 90% and 2.5 is 95%, and volatile organic reduction is 90% efficiency on that. So gases, you have seen this, and this is how it works. It has a 3 level: impingement, polarization, and agglomeration. That means trap and kill. And here you could find in the stage 1, we have a pre-filter where graded HDPP or long-lasting filters are there, effective for PM10. Then stage 2 is a polarization. Electron charge polarization needles, they enlarge this particle and effective on microparticles makes them thicker. And stage 3 is agglomeration, dual polarity, no arcing, and trap and kill germs. This is effective on PM 2.5 up to 0.1 neutron. So this is the kind of a report we have got. So some area nowadays we have started using the COVID robotics. They are a robot that are used contagion and virus control, that are able to generate high concentration of ultraviolet rays that destroys contagious disease. These can be used most effectively in the decontamination or detoxification of COVID healthcare facility, wards, transport facilities, and the like. Like this is the kind of a robo which you can operate remotely outside, because when UV is on, you are not supposed to get yourself exposed. Within few minutes, you can disinfect the entire area. For wards also, we have a striking solution. We call it light striking robo. These robos go around the ward. The moment a patient is discharged, within 10 minutes, you can disinfect the entire ward by running this robo. And the micro solution where you, and also the scrubbing. So UV technology to clean even disinfected a variety of hospital equipment, including wheelchair also you can put inside. So these are the things which are available. So thank you very much for your kind attention. And anyone who has any query can always be in touch with me. This is my email ID. And there are variety of things, but that we will be taking it up during our discussion. I thought I must sensitize you towards the little on a finishes, little on a copper, which is we are forgotten. Our predecessors have used it, and now that has become an essential item. Remember, we are crisis manager. We wake up when we get a call. So COVID has given us a wake-up call. So it is most important that we should take it. Thank you very much.
Thank you, Dr. Chandrashekhar. And as always, it's such a great knowledge bank that comes across after your discussion. More so regarding the optimization of copper and antimicrobial surfaces, about the magneto-control air cleaning systems, about the UV technology, and many such measures which we need today to augment what it is. Very rightly brought in, about 80% of the hospital-associated infection occurring because of the, these touch surfaces and, leading cause of infections. And while we are, as I mentioned earlier in my talk, opening address also, that these are the areas which are ignored. We spend a lot on processes, we spend a lot on air quality, we spend a lot on other process-related activity, but the activities which are related to the infrastructure, right at the design stage or maybe later, is something which we really need to look into. So thank you, Dr. Chandrashekhar, for enlightening us on these, and I can assure the people who are listening to us that there could be many more such areas of innovations which can be brought in. And though Right now, the costs are constraints, but I am sure over a period of time, as we become more aware about them, the more we are able to popularize them, the more their availability becomes. The costs also will be probably taken care of this. Now, to take it further, now I'll request our friend Dr. Vk Rana. In fact, again, like all other panelists over here, I have known Dr. Rana right from the time he entered the Quality Council of India and NABL, NABH days, and we had some of those most memorable times together in quality movement across the country. So I request him for giving his opinion on that. What difference do you think COVID has brought in healthcare infrastructure and design, both from a clinical and quality perspective? Dr. B. Rana, please. So while we are on to this discussion, we would move on to the clinical aspects or clinical perspective, and with Dr. Wali, with his vast clinical experience running into decades, I think he's seen the transition of the fact that from where we were on a very basic level, we didn't even understand HAIs. I remember my first lecture on HAI I conducted in Ganga Hospital. And from those days till now, that deeper and deeper understanding of HAIs is coming up. I request Dr. Wali to please take us to from a clinical perspective, what is the importance of reducing bioburden in commonly highly touched air surfaces? Dr. Wali, please.
Yes, sir. Thank you very much. I have the same request to share the screen, and I would be grateful if I could show some stuff I have tried to gather for this talk. You see, this is a big problem, as just mentioned by Dr. Chandrashekhar. 1 billion GB pounds, Great Britain pounds, is a big amount, and at the planning level, the hospitals have to see that their planning was intended to reduce the infection. They have in the Europe and America, they have a plus point that they have temperature which is lower than rest of the world. While the Asia and countries like ours, India, Pakistan, Bangladesh, they have a constraint of summers. They have a favorable atmosphere for the bacteria, not even bacteria, but some virus like novovirus recently identified, sir. And they have lots of negative side of the story, and that takes us to a very, very wide discussion on this, as we are rightfully doing, and changing towards cleaning techniques, introduction of newer materials, like once just now told by Dr. Chandrashekhar sir, and this is fantastic. I know that copper was very commonly used when we were young children in everything, including utensils and linings and furnishings, fixtures. Even latches used to be of copper, and handles, which it has been showing. My request for screen share is still pending. Khushbu, if you can help me, I have gone up to screen share. Please help me so that I can support my speech with slides.
Sir, you have
In the
shared the screen. मेरे को नहीं आया. I mean, I still have no option to your. Maybe you can share the slides once, and I'll put up on the screen.
Okay. Yeah, this is share option. I'm going to. Now you see. So in the meantime, I will keep talking. Slides. There is a hospital. Yeah, there is a hospital hygiene, and then there is a housekeeping policies. Then patient screening isolation, and then hand hygiene, as we have practiced for last 2 years. And then there is an antimicrobial stewardship. I have located this term stewardship, antimicrobial stewardship, and especially for housekeeping staff, in the recent past, it was decreased hours for housekeeping staffs and decreased hours of cleaning, which has led to increase in the hospital-borne infections. And the most horrendous tragedy is that the kind of microbials which are popularizing the hospitals are resistant to many antibiotics. So we have identified methicillin resistant microbials like Clostridium difficile and Acinetobacter, Novovirus, Pseudomonas, Staph, MRSA. So all these have contributed to increased burden, and that is what has led us to a very, very dangerous outcome as far as the patient care is concerned. There is another phenomena which is called repeated contamination of items. So there is a debate on the frequency of cleanliness equipment, which is everyday modernized, benchmarks, monitoring of the hospital hygiene and standard of surface cleaning parameters. So all these combined together, it starts from the disposable mop, which is changed to rayon fiber, which is resistant to all these microbials and cleans it nicely, microfiber cloths, and ultraviolet lights, and it goes up to robotics. So all this combined is helping us every day, and it depends on how efficiently we are doing this every day in day to day. So the basic principle is how to make hospital efficient. So one of the methods is to make the hospital of tomorrow a smaller hospital. There is an issue with these slides. Anyway, I'll read from here. The hospitals are expected to become smaller with fewer hospital beds. In addition, hospitals with trend to focus more on disease prevention, rapid patient workups, diagnostic tests, and treatments that should result in shorter hospital stays. So shorter hospital stays the hallmark, and hospitals will also increase the use of non-invasive interventions and implement the improvement in the outpatient strategies and home management. Primary care centers will be better staffed and more well equipped so that more patients could be treated without hospital admission. This is the most important point. And only patients with acute illnesses will be hospitalized. In other words, the concept of general hospital will cease to exist and a specialty hospital will take their place. This is the future landmark of the basis of prevention of these infections. And this is one of the major point which leads us to having more user-friendly hospitals. A time will soon come when hospitals will be more like 4 or 5-star hotels with large admission reception areas, open ventilated areas, shops, restaurants, self-contained areas, landscape gardens, all-day visiting hours, and rooms that will be equipped for families to stay with patients so that there is no outside communication for bringing in infection. Hospital rooms will also have interactive screens on which patients would be able to see their results and progress, as well as the request of consultants with their doctor or therapist. So there will be minimum mobility across and minimal cross infection, and it would lead us to lower the hospital staff. And as far as the routine hospital administration will be conducted via touch screens, and electronic medical records will update automatically if the test is ordered or when the results come in. Many aspects of the patient management will be managed automatically, thus reducing the need for doctors on the hospital's floor. That is what is the future role of doctors, that they would manage from their chambers the patients, and even procedures will be conducted by robotics. I had a very recent video in which the angiography, coronary angiography is being done in a cath lab, which is, as sir has shown just now, UV exposed and sanitized, and a robot is doing the angiography, so the patients will not be neglected. Every point will be attended, and nursing assistants will be there for routine aspects of the patient management. So these are the examples. Then their wider use of telemedicine also is a very big step in reducing hospital consultations and bringing in hospital-borne infections. And it is being popularized. When we were young, we were taught don't consult a patient on telephone by our professors. And now the telemedicine is a traditional way of doing it. This technology is easily applicable in several areas such as dermatology, radiology, cardiology. But in time, surgical techniques will also be enhanced, and remote telesurgery. Telesurgery will be used to minimize the infection, and it would be used widely. We have in Gangaram a unit in which we do robotic teaching also, and telesurgery teaching also, and we perform several operations successfully by robotic means, minimizing the hand touching the patient's organ, and robot will handle all the organs and minimize the infection. Thus performing surgical interventions, and surgeons will be able to use remote robotic arms without any need of actually visiting the hospital even. This is fantastic to hear, and maybe future, when next generation doctors come, we would hear that from the heaven that this is happening. Then use of robots will increase, as I said. They will be more frequently to deliver even food in the wards, other supplies. So what I mean to say, that there should be minimum human movement across to and fro in the various parts of the hospitals, and even the tests, interventions, even physiotherapists can be replaced by robots for exercise, and they can plan everything as programmed for individual requirement of the patient. And maybe one day it becomes more lifelike to converse and provide company to the patients also. This is very nice to hear, and this is future, of course. And non-invasive monitoring is again to minimize the infection. Use of non-invasive multimodal probes or sensors will increase to assess the patient heart rate, oxygen saturation. As I was reading in one of the papers published recently, that oximeters were also cause of transfer of infection. Then oxygen saturation, arterial pressure, temperature, respiratory rate, adequacy of skin perfusion, blood glucose levels, fluid balance, and data will be transmitted electronically, and further test or treatment will be determined accordingly. There will be no separate ICUs. While there will be still a department of intensive care, it may become sub-specialized. As per the nature of the patients admitted to the hospitals, it might be a possibility that instead of having a separate ICU, patients may be provided intensive care on their beds by bringing in a respirator, monitor, and all the equipment which is necessary in ICU, because ICU is the most dangerous place of having infection by a patient, as told by Dr. Chandrashekhar. And first 48 hours, we have patients going in ICU, coming back with hospital-borne infection through the ICU. A number of intensive care beds may increase regardless of their physical placement within the hospital. Then early patient mobilization would be the order of tomorrow. Patients may be ambulated early, maybe with the help of robots. Even those required to remain in bed may be helped to exercise passively, actively whenever possible. Since hospitals will be more user-friendly, patients may be more inclined to walk around and not will be confined to the rooms. Continuity between hospital and home care. We have started such facility at Ganga Hospital, sir, with due respect, and there's a patient follow-up and their assistance provided in most of the aspects, follow-up at home, and they have follow-up services, and we say them, go home peacefully, we are there to help you. Follow-up systems are likely to improve, and mobile teams may be used to intervene whenever necessary. Improved end of the life care is also part of preventing hospital borne infections. There will be more open discussion about end of the life choices in and out of the hospitals. Patient may have their wishes recorded early, and in case where patient's condition is likely to lead death and where further treatment offers no benefit, end of the life process may be started sooner, aided by open discussions. And all this combined, I would say that in the future, I'm just cutting short my talk because I'm sure we were there to hear Dr. Rana and there was a technical glitch. What message I want to give, that hospital of tomorrow has to be planned in a way in which minimum hand, human, and personal touch will be missing, as is required for us for the patient care, and more robotics would be introduced, more mechanized systems will be introduced, and more recently developed techniques to clean, to maintain the hygiene of the beds, around the beds in the hospital, even floor, and even the removing of the soil from the hospital. You see all these things, and we have seen that disposal of our PPE kits, gloves, and lots of materials which accumulated during COVID care was a big thing to deal with, and was a big cause of worry for all of us to how to attend to that part of the medical waste, which is add-on. So all this happening, we are here to plan for tomorrow, and with the very distinguished panel, I would submit that my humble views, I have just thought out of the box, and the future of medicine tomorrow would be entirely different than what have been practiced. But I would not forget my bosses having a white enamel dish and a ward boy carrying that and a fresh wash towel. That was the beginning, and that would be the end of the infection control. We should never forget that, as we have forgotten that. Now we have these bottles all around, in and out, with the bed, without bed, for us, which COVID has really taught us. And we should be grateful for this pandemic, that it has taught us, it has reminded us the hygiene in medicine, which we have forgotten in the recent decades. And that was catastrophic. And certainly we have to continue the research on the newer antibiotics and these strains in the bacteria and even viruses like novovirus, which are coming and which would be a disaster for human life and financial disaster at the pocket of patient. Thank you very much, Voice of Healthcare. Thank you, Khushbu, for providing me this platform, and your boss. And thank you, Dr. Rana, Dr. Lal, Dr. Yashpal Bhatia, sir. I'm honored to be with you today, and I am humbly submitting that I have really joined this talk to learn from you experts. Not I am the expert on infection control, and I am very delighted to be with this distinguished panel today. And my message is: be careful and avoid infections, save lives. Thank you.
Thank you, Dr. Wali. Thank you so much for such an elaborate point of view and passing us through the vision of what future of healthcare could be. Many of those may be sounding like dreams, but these are the dreams which come true. And what we are witnessing the healthcare today, I remember 2 decades back we could not have thought about many of those things, and 2 decades down the line, a lot of these things may be visible. So with this, I come back to Dr. Rana. I think there was some technical glitch when we couldn't have him on board when we were about to start. But I repeat that Dr. Rana and myself, we have had very, very close interaction right from the time when NABH started. In fact, we didn't know that it is going to be called NABH and it is going to be, we only knew that it was going to be the accreditation board. And there we started our journey together and seen lots of ups and downs together in our this journey through quality and accreditation, where he has been doing a really great job in putting India on accreditation platform across the globe. I think Indian healthcare fraternity will remain grateful to Dr. Rana for that effort, and it will be always remembered in that tone. And now, what new shape of things which are coming up under his leadership, we really compliment him for that. For today's discussion, to carry it forward, there's a area where we need your opinion, sir, and that's that. What difference do you think COVID has brought in healthcare infrastructure and design, both from a clinical and quality perspective? So let's have your views on that, Dr. Rana. And I would request
Thank you so much.
Yeah, if you can stick to time, because I think we are.
I would be very brief, sir. Thank you so much, Dr. Bhatia, for your wonderful introduction. It reminds me of our days in 2006 when we just started off at NABH, and I remember, and I should thank you and your family who has spared you for your days and nights sitting in the office of NABH and working on documentation. And thanks everyone, Dr. Wali and Dr. Chandrashekhar and VOH for giving this opportunity. Really delighted and honored to be among these leaders of healthcare quality infrastructure. So COVID-19, as everybody understood by now in last 2 years, has changed a lot in terms of infrastructure, in terms of practices. And when it comes to the clinical protocols, or it comes to quality in healthcare, I would say there are two things which are very important. One is infrastructure, we generally call it structures, and then the practices. I heard very well what Dr. Chandrashekhar mentioned about antimicrobial properties of copper, and I think that's quite interesting. And I have been following this topic for last not much, but just few years, particularly in pandemic, and really was excited to see how much it can be, brought changes to the healthcare in terms of reducing the bioburden. So whether it's a copper or anything else, and the design or the way of material you use, that's very important. But the practices are also equally important. Like Dr. Wali just mentioned and shown the bottle of the sanitizer. You have the sanitizer in hospitals, but no one is using it. So you have structures in place, but there is no use because practice is not there. So you are not going to reduce infections in hospital in any way. Second thing is practice itself. While practicing does not necessarily that your practice is right. It reminds me my several visits to several hospitals. When I ask hospitals that, can you tell me what is your hand hygiene rate? And roughly, I'm not looking for, you have to tell me exactly what is going on. It just tell me a range. And people will come up with a figure of more than 80%, say 80%, 85%. And I would always challenge them, and still can challenge that it will not be that much. It will be, I would say, within 50% of what you're claiming. And they would come back and challenge me that, no, it's not. And I would say that, okay, I would demonstrate you. And I take them, those leaders who claim that they are maintaining the infection in that way, to any ward, and then show them from a distance that this is how it is practiced. And you would see the nurses, and because nurses are the most empowered, I would say, in healthcare, because they are playing a major role in patient care and patient safety as well, and even the doctors. So everybody is consuming sanitizer. Everybody is using. Almost everyone is using. And then they will say, see, sir, everyone is using. Everyone is using. I say, absolutely. Everyone is, I can see they are using. And I can say your bill is going up because your consumption of hand sanitizer is quite good. But unfortunately, it's not going to work in reducing the infection. And simply why? Because they are not practicing it correctly. You just take few drops of hand sanitizer on your palm, rub it and finish it. It's not even, you are not following the standard practice of cleaning your hand using a sanitizer. So to me, it's just a waste. It's not going to serve any purpose. It's not reducing the infection rates in hospital. And then people understood that it's not only the resources which are required to control infection or prevent infection, the practices are equally or even more important. In terms of the clinical protocols in COVID-19, as we see that how frequently people have moved from one practice to another practice, because of changing situations and because the COVID-19 the disease caused by coronavirus, SARS-CoV-2, was not fully understood, and therefore there were a lot of challenges in front of clinicians and even nursing professionals to really look at that how they can work on. But thanks to the innovations, thanks to the healthcare professionals who have come up with newer ideas and newer ways of adopting things to fight with corona, fight with COVID-19 disease, and come up to improve quality. And I would say, if I'm not worried about quality, in fact, I was more worried about the safety of patients as well as the safety of the staff. So as you know that the COVID is so dangerous and it was so contagious that the staff was contracting. And if the staff is getting COVID and if they are not protected, they won't concentrate on the patient care and then might lead to the compromising in the patient safety. And therefore, essentially, it was very much required that the healthcare facilities must protect their staff and convince them, give them confidence that you are safe. You are being provided with all necessary protocols, necessary infrastructure in terms of PPE or whatever you need to make sure that you are safe, and so that they are confident that they're safe and they provide the safe care to the patient. So, in nutshell, what I would say that changing clinical practices, behaviors, clinical protocols, increasing the resources in terms of preventing the infection, controlling them, and also coming up with newer ideas like copper and with the antimicrobial properties of copper really need to be looked at, and how we can really shape the healthcare facilities in a manner that which can gives us optimum results, optimum outputs as far as infection prevention and controls are concerned, and maintaining a specific level, ensuring everyone is not just patient, everyone around in a healthcare facility, the patient, the visitor, the staff, everyone remains safe. And therefore, I think it's good and it's high time that we at healthcare fraternity, and I can see that the leaders, Dr. Chandrashekhar, Dr. Wali, Dr. Neeraj, and on top of Dr. Bhatia has been decades of experience in designing and executing the project in healthcare, to really look for the options which are better options, including, of course, looking for the possibilities of how we can channelize and socialize the antimicrobial properties of copper, in addition to many others which can be harnessed for the betterment. So I think just to conclude this, the statement is about that we should not be stopping here. We should be looking for newer arena, newer options and alternatives to make things better for everyone around. Thank you very much.
Thank you, Dr. Rana. I think very well brought out the optimization and balancing between infrastructure and practices, and the changes in clinical practice and behavior, and ultimately talking of cost-effective solutions. We know there are solutions. We know a lot of solutions are being brought in. But within our healthcare scenario, Indian healthcare scenario, where the patient affordability, the kind of payers attention which has to be there, the type of payment which are available through CGHS and through other payer agencies, ultimately optimizing the design with practices to prevent cost-effective solution. That is going to be the answer. Very well brought out, Dr. Rana, and we move on further to Neeraj. Mr. Neeraj Lal, who's CEO of Apollo Hospital Group. Again, like others, I have known him right from the time he was at Shalby. I think that was the first time we interacted. And hence onward, we have been, of course, last few years, courtesy COVID and other factors, I think we haven't had the opportunity to interact much. But he has put in a lot of effort from Shalby to Rainbow to now back to Apollo. So, Neeraj, I would like to ask you that since you are an active member and representative in various healthcare quality and assessing associations, in your view, what steps can be taken to reduce the HAVs, and what impact can antimicrobial surfaces play in reducing the bioburden, thereby reducing disease risk susceptibility? So let's have your opinion on that. And again, request you to kindly stick to the time so that we can finish the session in time. Thank you, Neeraj. Let's have your review on that.
Thank you, sir. I'll be very brief because I think most of the thing has been shared by Dr. Chandrashekhar, Dr. Mohsin, and finally Dr. Vk Rana. I'll be just sharing some of my practical experiences, what I have seen in Hyderabad, Bangalore, and now in Hyderabad. Sir, I think COVID, somehow I feel thanks to the COVID, I think one of the best thing in controlling infection is hands. If we wash our hands properly, I think COVID has taught not only healthcare professional, I think across the world, across the country, people know what is the importance of hand hygiene. I think this has been taught since the earth is born, and our country, our mother, our grandparents, whenever we enter home, we are supposed to wash our hands and legs while entering kitchen and while having food. And I think copper, what we talk about, sir, copper was still used in our country, widely recognized. And sir, we used to drink water from the copper vessels. There is one restaurant in Ahmedabad long time back known as Copper Chimney. So there, whenever they serve food, the spoons, the plates, and all things are there. I think the most important thing is lack of awareness and training. Say, for example, fumigation is not an acceptable standard, but used in many hospitals and they still use fumigation as a part of an infection control protocols. If you see, sir, HAI, sir, most common in our hospital is 𝐸𝐑, SSI, VAP, and all. So I think if awareness and training is given, the most important thing, the system is there, the process is there, but I think training and awareness is lacking is most important. One of the study which we have done in one of the hospitals is that the usage of cell phones among doctors and the microorganism which you found on the cells. So cell is a thing which most of the healthcare professional use for various communication and all. But if you do the microbiological analysis of the cell phone, most of the infection you found on the cells. So I think if we sticking back to the basics, use of antimicrobial surfaces like copper and training, I think that can change the way we work. Say, for example, in my experience in one of the hospital, because of COVID, no patient was coming to the hospital because hospital have ICUs, hospital have ward, and hospital is full of COVID patients. So what we have done as a healthcare project, we have taken out our OPD 200 meters away from the main hospital. There's a 40,000 square feet area where OP consultation rooms are there, which is where the patient is coming, seeing a doctors, and if at all they require admission, battery operated vehicles are there and maybe to take the patient from the OPD to various ICUs and ward. So I think minimizing touch and control of infection via training and awareness, that is a key what I have seen. This 𝐸𝐑s and SSI, whatever you see, everybody know this, what, like 35% is contributed by 𝐸𝐑, 20% by SSI, and 15% by VAP and all. And they're associated with much more health deaths and costs. So if we take care of these few things, and I think two things COVID which has done good. One is our health hygiene practices. Now also, if you go out inside the hospital or outside the hospital, people are wearing masks, but it is below the nose, number one. Secondly, they wear the cloth mask, small thing, and they're not washing their hand properly. So I think if we do training and lot of awareness among the hospital and use various AI tools in order to see and monitor our practices, we can become a safe place for our patient and taking care of patient. That's all for me, sir.
Thank you, Mr. Neeraj. I think very few words, but very, very smart words. I think these are the ones which have make all the difference. And, basically the minimizing touch, this is what you have brought out, that, if we can minimize the touch, it's what going to be contributing to minimizing the infection. And at the end of the day, not only the practices but the right practices, this is what makes the right way to go forward. And I'm sure if all our viewers, they follow part of it home also, it is going to be making a lot of difference to what it is going to be. Now we are coming to the second round of our this particular summit, and I'm going to have a more practical component of it. We have discussed lots on what we were thinking about, what we can, and how the context of the whole thing is happening. And with that, I'll come back to Professor Chandrashekhar for his experience and visionary contribution, what he keeps on doing to the healthcare organization. Sir, you have been in the design and architectural field for many decades now, and therefore you may have closely witnessed the transitions and evolution of healthcare infrastructure and design in the country. Could you take us through this evolution and share how the design strategy for today is different than what it was a decade ago, and how it is shaping up in the times to come? You have actually been on ground the part of all these things in the past, and right now also you're guiding so many states and so many organizations in how they're to shape up their future. Even yesterday during the Net Health Summit, I was seeing you surrounded by Maharashtra people taking your guidance on the way forward. So let's have your experience on the guidance to the this elite gathering also. Thank you.
See, the crux of the hospital planning lies in the space planning and the right kind of a space programming. COVID has made one thing very great. You know that whenever there is a larger amount of space wasted for waiting area, etc., the waiting area and the area which you are using is going to cost you. That is what the total investment. If you compare and what has happened, the 𝐒𝐓𝐑𝐿, that OPD in teleconsultation, I am keeping the crowd away. Only people who need attention has to come back. So what has happened in the earlier days, I used to have a larger waiting area. Then there used to be a lot of congestion. Then they will try to work out putting some air conditioner, something, and there always you will find an infection rate very high. Those who are coming outsider are bringing in, or they are taking some infection. And these kind of parameters, then we started using the artificial mechanical, forced mechanical ventilation. You push the air from one side and throw it out on the other side. But during COVID, we learned when you want to bring the air from outside air is also polluted. And when you are coming inside with this thing, again throwing it out, it is also. So we have to add certain system. Then best thing we found, do the teleconsultation. Like Dr. Wali said, human contact is reduced. That means you are controlling infection. And wherever possible, today lab, you can have that, person can come to your home and take the home collection. Yesterday in the Nat Health also, there was a presentation where they were saying 80% people or patient who are coming to the lab is reduced to 10 to 12%, because COVID has made it, everyone is scared. So he says, okay, when I can get the things done at home. So the main thing is now the hospital has shrunk. And second is our Prime Minister's program, the Wellness Center. Why bring everyone to the hospital? You can screen them right at their district or nearby area, give them a basic amenities, and that reduces. So these are the new things which is emerging. So Wellness Center is the one where, and there also we are giving them a teleconsultation in case the doctor's availability are having its own restriction. And we have started training the health professional of their community there itself. That becomes a helpful, because nowadays there are issues related with employment and other things. And like we have seen, lot of training program in yesterday's award function of CSR award, which was first time it has been happened in the Nat Health. There we could see two things. One is how we can outreach, to the remote area and help them, the tribal and those people who are not able to get the access, and how the training of the individual who can become a, torch bearer at the various locations. Like these are the kind of messages we have seen, and that is happening. So even in the Indo-UK Institute of Health, when they started, they said, have a major hospital at the proper location and screening center at various locations, so that a normal cough, cold and normal parameters can be handled. And even if you want, you can add your Ayush or the Indian system of medicine also part of it. So now whole the healthcare parameter has changed. It is not that everybody is going to come to hospital. And nowadays people have started, like Dr. Walia said, or even our Neeraj also said, that keep the OPD building separate, because COVID patients were coming in. So why mix up? And you can also function unit-wise. Now that OPD building is also can be telecommunication. So this is the variety of things which has happened. So I could say in a nutshell, the space has shrunk or it has disintegrated, so that the screening happens and only the clinical, serious clinical intervention where it is needed, people are coming to the hospital. Thank you.
Thank you, Dr. Chandrashekhar, sir. I think you're absolutely dot on point that, we have to work on reducing human contact in whatever way. And the trends are changing. The practice of healthcare is changing and transforming into how it can be done as remote as possible, so that ultimately the bioburden of being touched or being close is something which is reduced, and we move together to a area where though we always say that we are a community and we should be living like a community, but in healthcare we are moving that let's remain away from each other and not create a unhealthy community but create a healthy community. So this is what is going to be the trend for the time to come. To carry this discussion forward, I want to come back to Dr. Vk Rana. Dr. Rana, COVID has been able to create a much needed awareness drive among general public regarding the risk and the susceptibility to acquire infection diseases. It's all of us have gone through that phase when we were trying to avoid each other to make sure. That's the reason we haven't met for a couple of years, each other for that matter. And so this can susceptible to acquired infection disease and the related comorbidities beyond COVID. This is what has been the funda of the last 2 years. Do you think this behavioral change in the patient mindset has sparked a need for innovation in the existing healthcare infrastructure models? How do you think usage of material like antimicrobial copper fit in the present change scenario? Which, I mean, of course, one thing is public memory is very short, and a lot of people have already forgotten what they've gone through in the last 2 years. But at the same time, some of it will carry on, I think, and we have to bring in trends which will probably not let that situation come again, what we faced 2 years or 1 year back. Dr. Rana, please.
Thank you, sir. Thank you very much for this wonderful question. And I think, again, it's a matter of time and the behaviors. I think behavioral change is very, very important, irrespective of infrastructure or the resources being provided in a healthcare facility. Coming to number one point related to, say, the touch points, as Neeraj mentioned that they try to reduce the touch points. And as you mentioned, the antimicrobial properties of copper, how we can really harness these antimicrobial properties of copper in our healthcare facilities is use of copper in areas where are we call it high touch points, most frequent touching places where we can use copper as a material for use. Operation theaters, which are more susceptible and have chances of infecting the patients, can be another area looked at. In addition to these changes in terms of the material in infrastructure, the practices and mindset of patient is also required. And COVID-19 in last 2 years have forced everyone around to think differently. And as just Dr. Chandrashekhar mentioned about home care and telemedicine. And I think these are two areas which need to be really taken up most aggressive way, not only practice, but also to make sure that they are done rightly. So home care, as I know and aware of, and in fact, I'm following home care practices for the last 5 years. And at QAI, we were fortunate to develop a accreditation standard for home care services. And for the first time, not only India, but globally, and get it through 𝐒𝐓𝐑𝐔𝐂 international evaluation and successfully passed, becoming the first in the world to achieve that. And that has changed the perception of healthcare delivery in our society and community. How doctors were thinking, how patients were thinking, how the healthcare facilities were thinking about delivering healthcare. So home care has changed the whole paradigm that you need not to really visit hospital when you don't need to visit, right? You can get services at home. You can avail the services through telemedicine when you essentially not need to visit a hospital. Why unnecessarily visit a hospital and crowd it? And not only crowding and depriving those patients who really need an hospitalization. Why you're not sitting at home and receive the services? Why not you consult through telemedicine? And in fact, telemedicine again an area where we need to seriously look at. It's looks simple, but it's not that simple. And thanks to our the then MCI and currently NMC, who brought out telemedicine practice guideline in March 2020. And in fact, again, QI have been pioneer in developing accreditation standard for telemedicine, which has been now picked up. But what we want to make sure is that whatever practice you do it right. You follow as you do in hospital, you follow consenting process, you follow good medication practices, you follow the good educational practices to patients. So all these behavioral changes in the minds of healthcare providers, in the minds of the patient, that this is not was only the way. It's not the only visiting hospital can make sure that you are being treated properly. No, it's not necessarily. You can be treated home very well. You can through consultation, teleconsultation, you can be treated very well. So changing mindset, changing behavior in everyone's around is really very, very important. Then the last point I would touch upon is about the infrastructure itself in the healthcare facility, which we are using to provide care to patients. Look for options, look for alternates, the better alternates, and one of the alternates coming up, as I can see from the deliberation, is antimicrobial harnessing properties of copper, or maybe some of the alloys. It's not only copper, but maybe some of the alloys need to be really looked at, scientifically proven, what do we call evidence-based practices, proven processes. We may come out with a philosophy. Maybe I can urge all healthcare facilities around. Then why not to try and test what is being claimed that as copper has antimicrobial property? It has been proven somewhere in other part of the world. Why not we start doing here in India? We have a lot of healthcare facilities, and I'm sure that's the area. And Dr. Chandrashekhar, I think you are there into the helmet. Even Dr. Bhatia yourself, you have been pioneer in designing and in conceptualizing hospitals. Why not we come together and work on a white paper sort of thing, to look for the options, and maybe viable, most efficient and effective options in healthcare to minimize the bioburden, minimizing the infections in healthcare facilities, and therefore reducing the burden not only on the patient and provider, but also health checkers, the payers, which is more important. So I think these are some of the points just come to my mind at the moment to share with you all. Thank you very much, Dr. Bhatia. Thank you so much.
Thank you, Dr. Rana, and congratulations for achieving many landmarks like accreditations for the home healthcare and for telemedicine and many more things which have been achieved in the recent past, and very, very well deserved accolades from all of us for all those efforts. And the point is very well taken. I'll discuss with you offline regarding some of these things which we can probably work on together, and we'll move together on that. To carry the discussion forward, of course, I would request now Dr. Wali that, sir, how much difference will it make in a patient welfare, health of HHPs and visitors if bioburden in commonly touched surface is reduced and in turn reduce HAIs? How do you view the usage of safer infrastructure materials which have antimicrobial properties, and what are the trends which you feel are likely to become? In fact, your last talk was very visionary, and let's have your visionary views on this also. Sir, you are muted, please. Sir, you have to unmute. Dr. Wali, you need to unmute, please.
Thank you very much, sir, again. And I would say primarily First, we suffer when we carry infection from one patient to other. So it is our safety first. That concept I have to promulgate. We become the carriers in the hospital setup, in the emergency setup, in the ICU setup, and we carry. See, this is one. And secondly, as we are discussing the infrastructure, furnishings, handles, railings, all these structures, they are the potential hazards. We have to find places where we can replace disposables with the existing traditional clothings or things which we use. We have adapted disposable syringes, needles long back. This is one of the most important step we had taken and which is proving very beneficial. We used to treat on an average 2 injection abscesses in each OPD, which is not seen now. Now, the disposables have a better palatability for the patient also, like all the hospitals which you people have planned, they have provision for disposable sheets. They are changed after the patient is seen. Uh, we change the gloves and space for disposables. And the third thing which I have been feeling that minimization of invasive processes and as I said, the use of non-invasive multimodal probes, sensors to be installed, educate the staff, the doctors, increase to the access of the patient, heart rate, oxygen saturation, arterial pressure, temperature, respiratory rate. In America, I've seen disposable cuffs in ICUs. They don't use the same blood pressure cuff. Once the patient gets discharged, they throw it away. So such things would minimize infection and burden of this most important problem in day-to-day practice and adequacy of all the availability of these things, which would save actually costs and many gadgets can be disposable now and especially the human movement should be minimized by data transfer techniques electronically and minimum movement within the hospital and nowadays I'm seeing a post covid lot of attendants are coming with the patients again so this has come up so for the future we have to be very selective and as has been the highlight of today's talk, there have to be metals better and best is copper, which is a traditional metal we have been using in cookware. Always in our childhood, we had utensils of copper, and this was the reason probably that our elders have acquired. Copper had become out of use not because of ignorance, but because of its cost. So we have to really uh, get the copper, have the mining of the copper, and get copper like metals develop. We have recently seen that there is a metal called food quality steel and this is also one of the hygienic metals and but this is costlier than copper so copper would still be cheaper and then educate the paramedicals when we are not in the hospital at night if you go to a hospital the floor is being washed exchanges of water it's a small thing but all these things have to be very much supervised there's no supervisor at 11 o'clock when a hospital is being washed by an uneducated person who has no knowledge of infection control so all these things micro supervisions at all the levels and same way the linen of the beds linen of the examination room all should be done in a proper way this is how big way we can revolutionize these infections and this is one of the greatest killer of indoor care even the hospital visits so sir my humble submission is that at micro level all these things have to be managed and by expert like you it should be part and curriculum of the planning of the hospital to use maximum disposables and maximum copper-like products in future. This is my humble submission.
Thank you, Dr. Wali. Thank you so much for your uh, thoughts on how to move forward. We do agree that disposables and least human touch, and these are going to be the factors. And of course, we are to balance the cost vis-a-vis the overall. I think the more these things become popular, more there will be mass production. Like you mentioned about the disposable syringes. Initially, they were very expensive, and slowly, the cost came down, and ultimately, because now they are the ones which are in use, so it is impacted that they are easily at low cost available. Same thing happened with PPE kits when the pandemic started. The PPE kits were so expensive, and ultimately, the cost came down so drastically that everyone could use them, and now India has become an exporter of these particular products to the whole of the world. And so that's, I think, those trends will become better once we have that mass production, and these things impact the overall cost of healthcare delivery. Because what I always have believed in, it is not only the vertical towers of excellence which we have to create in the country, which will provide the excellence of healthcare. It's the horizontal spread of excellence in healthcare which is going to ultimately impact the healthcare system of the country and of the community. So we have to reach that. Mr. Neeraj, I come back to you. In your view, what can be other advanced ways to support clear and safer healthcare infrastructure? We have discussed many things, but we'd like to have your view on what are the other things which you feel that there are better ways of clear and safer healthcare infrastructure.
Sir, the few things which we are doing, I support Dr. Chandrashekhar what he is talking about a safer and a better healthcare. Like we have started a campaign, we are coming home. Healthcare is not restricted to the hospitals. Hospitals are gradually now going for like our OT, surgery, and critical care. So like in city of Ahmedabad, we have started Apollo Wellness Centers in the integrated society under the name Apollo Wellness Centers, which is Apollo Wellness and Medical Center, where a community of 10,000 or 5,000 people stays. And there is a wellness center where these people can go, show to a medical officer or doctor, get the test done and come away. They're not supposed to come to the hospital for the mixing with wards and the ICU patient. So therefore, similar structure we are doing in small apartments in society, so that in our campaign of we are coming home. Secondly, what we have done, there is a typical trend in the hospitals. Wherever a doctors or a patient or a staff come to the hospital, they are supposed to punch in and punch out. So we have installed a AI-based cameras. AI-based cameras, you are not supposed to punch in and punch out. Based on the AI photo, which is captured by these cameras, whenever you enter these cameras, take your picture and say, okay, you have entered at what time and you have gone out at what time. Proactively, these cameras also capture the mood of the patient or a doctor or a staff. Like say, for example, in the morning, they're coming with 75%, they're very happy. But when they're going out, they're 40% happy. So our HR head can say, oh, while coming, you are happy 75% and you're going 40% sad. So that get to know what kind of culture we are doing in the hospital services. I'll give you one example. A patient sitting in the OPD waiting for the doctor. Immediately, a AI camera will capture the mood of a patient. Patient looks sad. Patient look very ill. So proactively, our customer care manager go close to the patient and say, sir, I understand you're not very happy. So then patient will say, oh, it's a surprise, because he's just thinking by his mood. And then say, I'm not happy, I'm waiting for the doctor, he has not come, or I'm waiting for the billing, something like this. So I think we have to use these kind of technologies and structure to support healthcare. Don't limit healthcare to the hospital only. Now, nobody will come to the hospital for everything. I think we have to connect with the hospital while they're at home, while they're at their clinics. And only hospitals, because COVID has exposed the healthcare world in big way. I think everybody was talking about bed. So we should have these kind of wellness center, which Government of India is also planning, so that this integrated apartment and society can take a primary healthcare there. And if they require any procedure or a surgery, they can come back to the hospital. We have attempted with one, and we'll be doing more on that. And use of antimicrobial paints and all, I think this will change the way we work in healthcare.
Thank you, Mr. Lal. And I would tend to agree with you. These are very nice thing that you have started on analytics of patient mood from time to time, and
क्या करे वो?
yesterday we were looking into some of the startups, and we are talking of data. First is we don't collect this data, and second is if when we collect it, it just goes into the data banks rather than putting an analytics
Excel
into
sheets
that.
and all, big
Yeah.
Excel
So
sheets.
if we are able to put it together and modify our practices based upon that, I think that will be an excellent thought, and I'm sure it will lead to a great outcomes in the times to come.
Thank you.
I want to thank all the four speakers for such great inputs and such valuable discussion that we have had today. In fact, very enlightening, many thought-provoking, and many of the things which we would probably will be able to send to pass on to our audience and viewers, out of which they probably will come up with further innovations, which are it's like a multiplier. That if we suggest 5, it becomes a thought-provoking for 50, and when 50 work together, it reaches 500, and 500 when they talk about it, it becomes 5,000, and that's what it actually goes to the millions and ultimately billions. And some of these get implemented, and they become the trendsetters. So thank you so much, all of you, for bringing on those micro things which have been there, which have created the difference. Before I close, I invite all of you for a one-liner, your closing remark, before I give my closing remark today. So let's start with Neeraj. Let's have your one-liner, and then I'll move to further.
So let's move away from the hospital for the primary care. Everything is not into the hospital. I think let's focus on wellness center more and use of AI and technology for the betterment of care.
Thank you, Mr. Neeraj. And Dr. Rana, please, your comments.
Thank you. I would say that everyone should look for different options which are available, and just not restricting to what we have been doing for last several years, sticking to hospitals, but we should look for smarter options which are better, efficient, and effective for healthcare. Thank you.
Thank you, Dr. Rana. Very apt, as always. Dr. Wali, sir, can I have your comments, please? Sir, you have to unmute, sir. You have to unmute, please.
We should not get scared of the future costs. Future is brighter, and India is still in a position to have the best and cheapest healthcare. Our surgical practices have excelled the world, and when we talk of these measures, they can be as cheap as a bleach cleaning package up to the robot. So costs don't matter. It's the human life which matter, and for that we should do everything which is possible and coming in our way as advancements in this science. And I would support the concept of artificial intelligence and robotics in medicine in a great way.
Thank you, Dr. Wali, for very optimistic remarks, and that's what the future comes out of, that we put the challenges behind and move forward in a bigger way. Professor Chandrashekhar, for your final comment, please.
Like you have mentioned, 5 to 500, 500 to 5 lakh and things like that. I think it is start from every individual house and daily activity. You see, COVID has taught you the sensitivity of infection control and also the air quality. So it has to start from every individual, and that will multiply. And for that, any kind of a sensitivity you want to do, like those people were telling in media, they talk of 2 things. One is immunity booster, another is antimicrobial or antibacterial if you want to sell anything. So same way, this, when it is already in there, we have to say start from your own home and then village and then town and the country and the global. That is how what you put in 5 to 500 to 5,000, I have put it in a larger picture. Thank you. I think Bhatia Saab is network issues.
Hi, I'm connecting with Dr. Bhatia. Just a couple of seconds. I think he'd be able to join back.
Okay, okay.
Yeah.
Dr. Bhatia, I hope you could hear me.
No, I got disconnected. I'm back. So
Could you hear me at all, or you couldn't
yeah,
even hear me?
you started, and then that's the time when you were
Okay, okay.
talking
See,
about
what I
health.
said was that when
Yeah.
you talked about 5 to 500 to 5,000 and 50,000, how this thing spread, my concept was that we have to start from our own individual home individually, and how you have to take it forward to village and then to town and to the country and to the global. The same way, because everything like charity begins at home, infection control also begins at home. And that has been taught by COVID. And now everybody is used to, he knows the way Dr. Rana talked about that you are doing, sanitizer. But are you using the sanitizer properly or not? Are you washing the hand properly or not? Now people are educated, and media can also play a greater role the way they used to sell the immunity booster or the antimicrobial and antibacterial which they used to sell it. So same way, the thing should start from every individual, and it should take a real message. And one thing I'll tell you, the Swachh Bharat and hand washing, we started with the school children, and that took off very well. So same way, our younger generation has to be given a good direction. That's it. Thank you.
Thank you, Dr. Chandrasekhar. I think you are absolutely right. Charity begins at home, and we have to start from the younger children. We had practically, almost similar experience when we were talking of leprosy eradication programs. And in the leprosy eradication, what we used to do, we go to school children and teach them on how to detect the early symptoms of leprosy. And that's how we could reach people and eradicate the leprosy even before it came up with the symptoms of leprosy. So I'm sure this will be how it will be. With this, I do thank all the faculty for this evening, and thank you so much for bringing out such an innovative ideas and thoughts. I would like to sum up that ultimately, if we have to succeed in our program, the innovations are the part of it. However, the thought and the concept has to start right from the design stage. When we are designing the institutions, that's the time these steps, these infrastructure changes are not going to cost much. But if you want to do a change management later on, that's a very expensive exercise. Not only that, people have already used to practicing it in the way it has been designed. And you change the design, and then you ask people to change the practices, I think it is very difficult for them to adapt to them. And the change management is a very expensive exercise by itself. So, right from the time when we are designing a healthcare institution, let us think of this innovation. Let us think of it that my hospital, my institution, my wellness center is susceptible to infection. So, might as well start putting them into plan right on the day I put my drawings on a drawing board before putting them on ground, and later on suffering out of it and trying to innovate, trying to renovate, trying to put the and along with that put right environment, right practices, right awareness, and right knowledge into these things to happen, along with the innovations of the thought, that least contact, the use of copper, the use of telemedicine, the use of, what Dr. Wali said, smart and small hospital. Now, all these things are going to make a difference. And there's no one step which is going to be sufficient, but each step is going to be baby step to actually overcome what the problem of the discussion today was. So with that, I thank the VOH for having organized this hospital healthcare infrastructure summit. I thank all of you individually, Professor Chandrasekhar, Dr. Wali, Dr. Rana, and Mr. Neeraj Lal, and of course the hosts from the VOH who had so beautifully coordinated our exercise. And before I end, all those people who are attending the summit, my grateful thanks to them for taking out the time, listening to our expert faculty, and hopefully carry home some of the messages which have been brought today, which will be acting as a catalyst for transition, for the change, for this healthcare infrastructure summit and its aim have been meant for. Grateful. Thank you very much. All the best.
Thank you so much. Thank you, sir. Thank you very much. Jai.